It is a real pleasure today to introduce our guest speaker, Dr. Veronica Gunn. She is currently serves as the Vice President for Population Health Management and Payment Innovation at the Children's Hospital and Health Systems of Wisconsin. In this role, Dr. Gunn facilitates the efforts to improve the health of children, lower the cost of care, develop new payment models, and enhance the patient and client experience. Piece of cake. Really straightforward. Dr. Gunn completed her medical degree at Vanderbilt and her Master's of Public Health and her residency and her chief residency at Johns Hopkins. She served as the Chief Medical Officer for the Tennessee Department of Health. She's lectured nationally on various topics and specifically on applying evidence to improve the health outcomes for maternal and child health populations. She has received, I was reviewing her CV this morning, she's received numerous awards. A few of them include the National Business Journal's Woman of Influence and Public Policy Award and the March of Dimes Healthy Baby Advocate Award. Please join me in welcoming Dr. Veronica Gunn.
Thank you, Dr. Cora Bramble, and I'd like to thank Dr. Newman and Elizabeth Flory for the invitation to join you this morning. As said, I am Veronica Gunn, and I have the pleasure of serving as the Vice President for Population Health Management and Payment Innovation for Children's Hospital of Wisconsin. Over the next 30 to 45 minutes, I'll share with you a little bit about our system's journey to value. And I want to welcome those that are watching via WebEx and I invite you to think of some questions if you would have them. My goal is to be as transparent as possible so we can have a shared learning experience. I have no conflicts of interest to disclose. And the objectives for our time this morning are listed here. Really, it is simply put to have a bit of time of shared learning, to recognize that our system's journey was started for a very different why, perhaps, than your system's journey, but there's still learning to be had from both. I want to share with you our approach in Wisconsin and as well talk about the market influences on our journey, and last but not least, to share some lessons learned. But to get started, I want to start with a case, because everything we do at children's hospitals, we do in service for our kids and families. And so let's start with a few details about Lucy. Lucy is a real patient of one of my partners. That is not her name, and this is not Lucy. So this is representative of Lucy. Lucy is an 8-year-old who has insulin-dependent diabetes mellitus. And Lucy has been admitted to Children's Hospital of Wisconsin many times in DKA. She and her mother received care from our diabetes clinic and primary care at our Children's Medical Group primary care providers. After many sporadically attended appointments in which Lucy's blood sugars were frequently not within control, Lucy's pediatrician became concerned that her mother may have low health literacy that was impeding her ability to effectively manage Lucy's diabetes. There's just a few facts about Lucy. We will come back to her later in the presentation. But I want to start first with why we are motivated to improve the health of pediatric populations, because I think it's really important to first understand the motivation of systems on this journey, because everybody's different. We have a lot of similarities. Children's National Medical Center and Children's Hospital of Wisconsin both have an over 100-year history of serving children who have unique needs. Children's Hospital of Wisconsin was started by 7 women who recognized that the unique needs of children in medical or chronic distress were different than that from adults, and started that hospital, which continues to thrive and now a suburb of Milwaukee. Also, like you, we are more than a hospital, and I share some of these attributes because they are unique to how we're approaching population health. We have over 100 primary care providers, and we have over 40 locations throughout the state of Wisconsin, 360 pediatric specialists, community health and education unit, which I'll tell you a little bit more about later, and some some truly interesting aspects. We own a social service agency, which I'm not aware of any other pediatric health system in the United States owning. And that social service agency provides foster care and adoption services, as well as child well-being, screening, and support. We also own a Medicaid health plan, which you'll see listed throughout the presentation as CCHP, Children's Community Health Plan. We insure about 143,000 lives, a little over 2/3 of which are kids. And we provide dental and mental health services. So, and similar to your organization, we enjoy recognition in many aspects, recognizing the caliber and quality of the care that we provide, as well as the quality of service through our social service agency, which is the COA accreditation. And it is in this context that Peggy Troy, who is the CEO of our system, and her senior leadership team joined the system in 2009. So in 2009 and 2010, as many new leaders do, they assess the current state. Where are we, and what are we achieving, and what path do we want to set for ourselves? And in 2009 and 2010, Peggy Troy had a hospital and health system that by all general measures was succeeding. And yet, when they looked at child health outcomes for Wisconsin, the health outcomes for kids in Wisconsin was just over the median for the United States. And when you looked at child health outcomes for Milwaukee, there were significant disparities in health outcomes and lots of room for improvement. These data are from 2010, and they represent data from 10 census tracts of communities with whom we now partner to improve the health of communities in which children live, learn, and play. And you can see 18% childhood obesity, 18% prevalence of asthma, and an infant mortality rate of African American children in that community that's more than twice that of Caucasian children. So given this dichotomy, leading hospital and health system with all of these assets, and yet child health outcomes in our own backyard left a lot of room for improvement, that is the context for our population health journey. The system, Peggy, the board, the senior leaders, including the clinicians, set as the vision that we would have the healthiest children in the nation living in Wisconsin. And it's important to note that they did not say the children with the best health care living in Wisconsin. They said the healthiest children. And they endorsed the World Health Organization's definition of health in that statement, meaning a complete sense of physical, emotional, and social well-being, and not merely the absence of disease or infirmity. So that's a pretty audacious vision to set. It's also nice, right? Who doesn't want the healthiest kids? And I'm sure you guys want the same thing, right? And in fact, many of our colleagues at other children's hospitals have very similar visions. But this vision and its audaciousness are what made me move from a slightly warmer climate to Milwaukee, because it acknowledges to achieve this vision, you have to recognize that that's a population health focus, and that when you understand the drivers of health outcomes of a population, high quality health care and access and utilization and insurance contribute 10, maybe 15% to the health of a population. There are many more factors that influence health outcomes more. So for example, the social environment and culture, genetics, and the greatest contributor to health outcomes, health-related behaviors. And as you all know, as well as I, for a pediatric population, we're not just talking about children's health behaviors, we're talking about the health behaviors of the adults that care for them as well. So if you have just endorsed a vision that says we want to have the healthiest pediatric population in the state, and as a healthcare delivery system, we can directly influence maybe 10 to 20% of that, that is pretty audacious. So we have to figure out, how do we partner effectively? How do we understand those drivers of health outcomes that are not related to clinical care? And how do we influence those? As a system, we have some unique assets, And while we own these assets, that does not mean you have to own the assets to affect change. Let me show you some. This slide represents some of the care continuum that we have in our system. From the prevention and wellness space, which is in the green to the left, these tend to be programs and services to help children and families stay well, from a variety of e-learning programs to injury prevention services. The yellow, the middle, represents risk-based services and programs for children and families who are at risk of having a poor health outcome, at risk of having a poor family outcome. Remember, we do child welfare as well. So when families disrupt and children come into foster care, that is a negative outcome that we want to avoid. And of course, we really excel in the red side of this continuum, in the high acuity, high intensity services for children and families who are experiencing distress. Our commitment as a system is that we would utilize the breadth of that care continuum to improve health outcomes in a different way. So that's the context for our population health journey. It was first by mission, and I emphasize first because we'll come back to, so what about the value and the payment innovation? But what I'd like to share with you next is how we are approaching redesigning care delivery and why we've invested in it in the way that we have. Because every health system, you've met one health system, right? So because every health system is organized in a different way, and it makes a difference as to how you approach your journey to value. I want to share a little bit about how our health system is organized. And I think it's fairly similar to yours. You heard me reference our primary care practitioners. We have just over 100. Those are employed by our health system and dispersed primarily through the southeastern part of the state, most of which are concentrated in Milwaukee and the 6 counties surrounding that. We also have a joint venture with the Medical College of Wisconsin, which is an independent nonprofit medical school for our specialty practice. We have over 360 specialists. These are our hospitalists and our specialty providers who are employees of the medical college that work within our hospital system. We have 2 hospitals, a freestanding children's hospital that is located in Milwaukee and a hospital within the hospital about 100 miles northeast. And we also have this really diverse set of programs and services that we have encompassed in what we call community services. And that diverse array of services, some of which are listed here. You heard me reference our child well-being unit. That's over 400 professionals, including therapists, counselors, family case managers, social workers, that are distributed in over 40 locations throughout the state to primarily provide child welfare services, child and family counseling, and family case management services. We also have the Medicaid health plan, which you heard me refer to. Right now, it's a Medicaid health plan. We will be expanding to commercial products in 2017. And we have a children's community health and education unit that does everything from developing educational content in the traditional way. So we used to do health education content for schools and deploy that to schools. We now do e-learning and a variety of other services. And community support. Elizabeth has heard me talk about one of our main tactics, one of our tests of change is an investment in helping build capacity amongst communities in which children live. And I'll share a little bit more with you about that later. So that's how we're organized, which again is relevant to how one embarks upon a value journey. In 2012, so 3 years ago, Children's Hospital created a department of population health management and payment innovation. That is a mouthful, I know, but the words were intentional because we wanted to make sure to link redesigning care delivery with new payment strategies. That department has 2 charges. This is the department that I lead, and it has 2 charges. The first of which is to design innovative care delivery models that lend themselves to the triple aim: better health outcomes, better experience, lower the total cost of care, and that lend themselves to a new payment methodology. So this is important distinction. This is not the same as performance improvement or quality improvement. We have those initiatives within our system as well. This is disruptive innovation. So this unit is intentionally designed to do product development. Think smartphone. We're trying to develop products, except those products are healthcare delivery products. And we're trying to sell them to payers using new payment models. The second charge of the department is frankly the hardest of the two, and that is to facilitate the change management associated with moving from volume to value. Because our charge as a department is to be disruptive within an institution like healthcare that generally does not disrupt quickly, we intentionally recruited individuals who had a variety of backgrounds, and specifically not from healthcare. So we have a team of 9 FTEs in our R&D unit, and we're expanding our packaging and marketing, for lack of a better word, unit, which has 3 FTEs in it now. And you can see the responsibilities of those individuals on the team, as well as the backgrounds, experiences of those teams. And I'm happy to talk about any of these in more detail. I want to maintain sufficient time for Q&A so we can talk about things that are relevant to you. I'm going to share with you our methodology. So we have designed using principles from quality improvement, methods that we've pulled from performance improvement, as well as from public health, frankly, to design an approach strategy to understanding, to first soliciting ideas. How might we do things differently? And we solicit these ideas directly from the business, from the providers, from the operational leaders who have great ideas on how we could do things differently. And we typically start these questions with, what if? Fill in the blank. What if we could do blank differently? We have an approach that allows us, and have developed tools that allow us to thoroughly and methodically evaluate the merits of any given potential tactic or idea, improvement idea. So it allows us to have both rigor as well as to support innovation in a way that we would like to see expand our portfolio as a system. As we engage providers, remember, part of our charge is that change management and developing that skill. So as we engage providers in fleshing out the hypotheses from a question of what if to let's identify several concepts that we want to test about this population, we help our providers and our operational leaders develop skills in risk stratification, for example, as well as understanding how utilization happens. So we use a variety of data sources, certainly healthcare data, but we also use claims data. And frankly, we use any data set that can give us a true insight into what's driving the health outcomes for our population. Some of the examples that I'm sharing with you here are from an asthma initiative that we started several years ago. And one of the, many actually, of the providers and clinicians in that group hypothesized a variety of theories of why we had poor asthma outcomes amongst this population. And the population in question here were our children in our Medicaid health plan. The question was, what are drivers of poor asthma outcomes for children in our Medicaid health plan? So not surprisingly, based on their experience and on the literature, many people thought, well, perhaps it's lack of appropriate diagnosis, recognizing a chronic versus an intermittent condition, not prescribing the right medications, not filling medications, families not adhering to medications. And there was some suggestion that external air quality might be contributing to poor health outcomes for children with asthma. So we used a variety of data sets, including claims data, clinical data. We used EPA air quality data, public health, immunization. And what it turned out is that the largest driver of poor asthma outcomes for our population was indoor air quality, not actually any of the others. So the prevalence of environmental tobacco smoke and other triggers in the home. And the only way we got that data was because we were able to access public health data on home surveys. So because we were able to utilize a variety of data sources, it helped us be more targeted in our interventions rather than assuming the drivers of health outcomes are the same for all populations. We define populations in a variety of different ways. We don't just define a population based on a condition like asthma. We also define populations based on geography, for example, where kids live, or by a payer type, age group, or experience, for example, the experience of being in foster care. And so we develop different models of care delivery based on those unique populations. We also have different methodologies for the type of model that we're developing. Most of our models are care redesign or service delivery models. And an example of that is clinical navigation. But some of our models are around populations themselves. So, for example, how to manage patients in a narrow network arrangement. And some of our models are simply payment redesign models. For example, you have a phenomenal model of service delivery for children with medical complexity that has been demonstrating value to payers for years, which means you're not getting paid for that service, but you are saving those payers lots of money. How do we change the payment methodology for that so we can sustain that service in the long term? So I'm going to share with you a handful of examples of these various tactics that we are testing, just again for some concrete examples, and then we'll shift to the so what around value and payment. Well, this first one is Children's received a CMMI Healthcare Innovation Challenge grant in the first round, and the hypothesis that we proposed there is, could we affect care utilization of healthcare services by high utilizers of healthcare by utilizing a low-cost service called a navigator, a community health navigator, and a nurse navigator to support connection with primary care and to connect those families with unmet resource needs. So for high utilizers of healthcare, they are offered the services of a health navigator who is a layperson, not a clinically trained individual, who goes to their home and meets with them in a capacity-building way, helping those families identify unmet needs that may be challenging their ability to address their health outcomes. And nurse navigators are available via telephone to support individuals' chronic conditions, to help them meet their chronic condition needs. We have just wrapped up the implementation of this pilot study and are in the evaluation phase. We're using, again, primarily claims data for this particular question, which is, are claims lower for individuals who receive navigation compared to those who did not? And I will say that preliminary, because we have not finished the analysis, but preliminary results are very promising. And it does appear that we were able to effectively reduce ED utilization significantly, as well as lower the total cost of care. In the future, one would anticipate, we tested this in a capitated model, and so this certainly can be done in a capitated way. It can also be done as a billed service through perhaps some other type of value-based arrangement. Our next pilot that I'd like to share, we call community engagement. And I had alluded to this before. This is a long-term investment in partnering with 3 neighborhoods in Milwaukee. And these 3 neighborhoods were selected because there was a high population density of children, because child health outcomes in these communities were so significantly challenged that we felt like we could measure some improvement within a reasonable period of time. And I will say reasonable for, as you all know, for moving a population-based metric is not 5 quarters, is not 5 years, is some period of time, 10 years, maybe 15, but is not a lifetime, which is if you pick a population where there is a small room for improvement, you're going to be at it for a long time before you can demonstrate improvement. The approach here is very different than one that we have typically used. It is capacity building with residents, literally meeting with residents of the communities to help them develop the skills that they need to affect the change they wish to see in their communities. When we met with the residents of these communities and asked them what a healthy Metcalf Park or a healthy Amani neighborhood or healthy Lindsay Heights neighborhood, what that meant to them, none of them said, having a Children's Hospital of Wisconsin clinic in my neighborhood is, the equivalent of healthy. None of them said that. Every neighborhood said having more green spaces, having safe places for my kids to play, having fewer boarded up buildings. And I think one of the responses that struck me, seeing fewer young people in wheelchairs because they have been affected by violence. This is what these communities wanted for their children, and that is exactly what all of us would want for our children and our communities. Why we have chosen to invest in this approach is because we know in the long term that the only sustainable way to improve child health at the population level is to support the communities and the families in which kids live, learn, and grow. We are a healthcare system like you, and so we don't do housing. We don't do violence reduction. This is not our wheelhouse. What we do well is clinical care delivery and capacity building. And so we have promised in this setting to leverage the skills that we have as a clinical care delivery system to support those communities. What that looks like for us is we employ and place school nurses using an evidence-based coordinated school health model of nursing in schools in these communities. These nurses are extensions of primary care. They work with our community health navigators, whom we have hired and placed in these communities. And we also, at the request of the community, have instituted 2 family care clinics. We're a pediatric health system like you. We don't do adults. So we had to partner with an adult provider. And we have 2 community-based clinics in community centers in these neighborhoods that serve children and their caregivers. We are evaluating this particular long-term investment on many different levels. Certainly the population-based measures, we do not anticipate to change in some time. We have been at this for about 3 years. We have recently started looking at our service delivery evaluation. So for example, in schools where we have a Children's Hospital of Wisconsin school nurse, are asthma outcomes better than asthma outcomes for children who are in schools without one of our nurses? And again, early trends are very promising. It appears that children who are in schools where we have a school nurse placed have better asthma adherence to preventive asthma meds, have better utilization of preventive services, including primary care, and have high return to class rate, which is all very promising. The next is our system immunization initiative. As a system, when we embarked on this population health journey and this commitment, immunization outcomes in Wisconsin were really pretty poor, as you can see in that middle column there at the bottom, 64% up to date as a state, and this is for 2-year-olds, up to date for 2-year-olds. So across our entire enterprise, we developed a process and a protocol for assessing up-to-date status for every 2-year-old we came across, not just in the hospital, not just in primary care, in our health plan, in our social service agency. So at every touch point, children were screened for up-to-date. And if it was a clinical entity, they were brought up to date if they were not up to date. If it was a non-clinical entity or an entity that was not, could not maintain immunizations or vaccines safely, then that child was referred to their primary care practitioner to be brought up to date. All administered immunizations were entered in the state's immunization registry. And you can see that in the 5 years since we have started this endeavor, there have been measurable improvements in up-to-date rate, not just across our health system, the kids that we touch, but also in geographic areas where we have a presence. I want to be clear that this is not attributable to Children's Hospital of Wisconsin alone. This is done in strong partnership with public health and with other healthcare delivery systems in those communities. And then the final example I want to share with you is one of a commercially insured pediatric population in a narrow network arrangement. This is a narrow network product with about 14,000 children in it. And what we were able to demonstrate in this particular tactic is that Children's Hospital of Wisconsin, that's CHW members, the blue bar on the left, the pediatric providers there were able to manage to a lower total cost of care on a per member per month basis than expected compared to non-Children's Hospital of Wisconsin attributed members. Now, the dollar amounts may not look like a lot, right? But when you think about thousands of children over 2 years, this amounts to about a $1.2 million savings over the 2 years of this particular trial. This represents 14% efficiency in the service provided by primary care providers. And the learning here was really important, helping providers understand about attribution. I'm a primary care provider, and so I know the patient in front of me. I need to understand about the thousands of patients that are attributed to me that may never come to see me, and how do I reach those individuals. Also helpful to understand about performance analytics and continuum of care evaluation. So let's come back to Lucy. So you remember Lucy is the 8-year-old with insulin-dependent diabetes, hospitalized multiple times for DKA, has been seen by our specialty practice, has a primary care provider at Children's Hospital of Wisconsin who is concerned that maybe Lucy's mom has low health literacy. So this actually is a patient of one of my partners, and when she was telling me about Lucy, I said, well, why don't we have one of our community health navigators that serves Lucy's community go meet with Lucy and her mom. And so we did that. We referred her to one of our navigators who went to meet with Lucy and her mom and learned that they were effectively homeless, that they were moving from willing friend or family member as possible, but squatting in abandoned buildings many of the time. And so frequently they were out without electricity, let alone a refrigerator. And of course, you know, insulin to maintain its effectiveness should be refrigerated. So Lucy's poor diabetes management was not the result of an unwilling parent or not the result of a parent who had low health literacy, but a parent who had a job but no stable housing. And Lucy had been receiving care in our system for years. And when the navigator asked her, why didn't you tell anybody? All of these providers who would care about that important fact, why didn't you tell anybody? And her mother said, why would I? Your healthcare, what would you do about it? And again, to the disconnect that frankly we feel too. We didn't ask. We didn't ask, and she didn't think it was relevant to tell us. But in order to really understand what drives health outcomes for aspects of populations, you need to understand and be able to mitigate those social influences on health outcomes. Now, happily for Lucy, the navigator worked with Lucy and her mom, worked with Lucy's mom to help her understand existing resources for housing, and even did some role play with her until she felt comfortable navigating, frankly, the complex systems that social services often are. She now has stable housing with appliances and electricity, and Lucy has not been back in DKA since then. So it's just one story that's illustrative of a low-cost intervention, a community health navigator, as an extension of a primary care practice or care delivery system that can have a significant impact on quality of life, health outcomes, and total cost of care. I am certain that there are some of you out there going, well, that's fascinating, Veronica. But really, so that's sweetness and light, that's mission. How on earth are you going to pay for this? You know, so what of the cost? And very valid question. Before we embarked upon this journey, before we started the first tactic, we actually did some financial modeling in our system. And the thinking at this time, so I'm going to back us up to 2011, which is when we did this financial modeling, when we were 99.9% fee-for-service in our hospital contracts. And quite honestly, we're not too far from that right now. In our hospital contracts, we were doing quite well, and there was really no interest in jumping into value, because why would we put our revenue at risk, right? Well, so our thinking was looking at what we have seen in the healthcare market and then at the national level and in our state. Here are some facts that we recognize. One is that fee-for-service was declining. So reimbursements were declining, contracts, particularly for adult systems, we had not experienced this yet ourselves, were being driven down. So we knew that this would happen eventually for us as well. We also clearly knew that after the passage of the Affordable Care Act, that new models of care and payment were emerging, and that a number of payers, starting with public payers, but now clearly moving to commercial as well, were driving more towards that value-based model. And quite frankly, we wanted to drive our own fortune. So when we did this modeling, it was in the interest of how can we develop the skills and the competencies that we need as a system so that we can establish the argument, so that we can contract and negotiate on our own terms rather than having to respond. When we did this modeling, we recognized that first, if we jumped too soon, we did lose a lot of revenue. If we jumped too late, we lost a lot of revenue. In other words, we would not be able to sustain our system in the way that we currently are sustained if we didn't transition soon enough. But even when we timed it well, there would still be less revenue overall. And so that's just the factor that we know for our system. There are a number of shaded areas that you see on that graph. So one furthest to the left says growth of CCHP membership and minimal risk exposure. We have been utilizing our Medicaid health plan to test many of these models of care delivery because it allows us to realize savings, or hopefully realize savings in one area of the business, but minimal risk exposure in that when we diminish inpatient admissions, we lose hospital revenue, but we maintain that revenue on the insurance side. So minimal overall system risk to us. We've been utilizing that as our learning lab. We are still early in our journey towards value. And what will facilitate our transition zone right now is going to be our adult partners, and I'll tell a little bit about that in a second. The commercial risk appetite and the increase in commercial risk appetite, both for us but also for commercial payers, and Medicaid SSI. So Medicaid has been a fabulous partner with us, and SSI, as you all know from your CMMI grant, is a population that also will help us manage this gap. What has happened in the interim? So since we've done that modeling, remember we were making very good money in a fee-for-service world. What's happened in the 4 years since then? Well, payers have been moving more and more aggressively to move risk to providers. And commercial payers certainly are aggressively renegotiating their contracts now. The public and private insurance exchanges are providing more options and pricing transparency, not cost transparency, but pricing transparency to consumers, which is sometimes complicating the value message to consumers. And unique to our market, I don't think you guys have experienced this, new narrow networks have formed among the adult systems to give adult systems more scale. And this is impacting us. These are two maps of Wisconsin, and what has happened in Wisconsin is just about every large adult system has picked a side and has chosen to participate in one of two mid-narrow networks. And if you participate in one, you cannot participate in the other. Each mid-narrow network would like for children to pick a side. Now, I don't know about your experience in DC. Actually, Kurt was sharing that you guys have a slightly growing population. Not so in Wisconsin. We have 1.2 million children, and you cannot divvy that up and maintain the high quality and caliber of service that you expect to give to your patients expect. You need to have as much volume as you can to maintain that caliber and quality of service. So this is a big driver for us, and in fact, many of these adult systems are also starting to pick off some of the commodity services for those young adults, which I think is a ubiquitous challenge for pediatric health systems. So our conversations with payers as well as with adult systems are along these lines. First, that we have to maintain scale to be able to maintain the highest quality outcomes and not duplicate high-cost services. And payers and adult systems need to understand that they need to leverage the unique expertise in pediatric management for a variety of things. For those adult networks, and they're finally honestly starting to get this, they are at risk. When we effectively manage a pediatric population, we hand off a healthier adult population to them, which is what they want. And so we need to be able to not just articulate that, but demonstrate that through several of our value-based initiatives. And importantly with payers, as I'm sure is your experience as well, you need to understand the measures that of value unique to a pediatric population are not the same for an adult population. The number of times you've been approached with a contract for value that measures your coronary artery bypass graft readmission rate, you know, that has no relevance for us in pediatric health systems. So we need to help those payers identify unique measures of pediatric population-based outcomes. So we do a variety of supports now in our system. We work with other pediatric health systems to help them establish their pediatric infrastructure. We also work with systems to manage a specific population, and we're working with payers in states and some other systems to manage their overall pediatric population. So in wrapping up, if you have questions, think about those questions via the WebEx. I wanted to share with you some key learnings from our experience thus far. And like I said, we are barely 3 years into our population health R&D journey. What we've learned is you have to have a clearly articulated why. What is the rationale for this journey? As I shared with you, it was first mission. It's the right thing to do. It's consistent with us as an organization. We are driven to improve the health of kids because that is our commitment. And it is also financially the only sustainable way for us to thrive in our market. And so we need to understand that our why is both and. For some, the mission will be compelling. For others, it will not. And so you need to be able to understand what is your driving force and how do you share that with your various constituents. It's also important to invest in facilitating change, and I don't think this can be overstated. People understand the technological support. That's very tangible. You need an EHR that allows for an integrated care delivery. You need tools to be able to identify and track populations. That's very discrete. What I think often gets underestimated is the investment in developing the competencies to move from me as a practitioner who is trained to treat the patient in front of me to a practitioner that understands the management of a population, many of whom I will never see in the clinic. How can I be accountable? How can I know where those individuals are? How do I know how to stratify finite resources to allocate to those that need it the most? How can I measure my performance if I'm not doing this based on RVUs? All of those things require training, frankly, and investment of time to support this change in how we behave as a clinical practice. Senior leadership and culture management is important. As our healthcare delivery system, like I said, we wear our mission on our sleeve, and it really is one of the most compelling things, I think, about this system to me. And at the same time, when you define our mission as the child in front of you, and not the child you can't see, or the child that may be getting care by the adult partner network, you have to shift your mindset to understand how we approach and support all of those kids that we have now made ourselves accountable to by our mission and by our vision. And so we have invested a fair amount of time and resources in supporting the development of culture and value amongst our senior leadership team and now throughout our entire system. And we have invested in identifying and supporting values within our system and offering some coaching about those values throughout our leadership team. Being attentive to market changes is not a surprising key learning, and something that every health system is doing. I think the more specific learning here is not just what's happening in your market, but developing the skills to understand and do some modeling on the so what. What are the implications of the emergence of 2 mid-narrow adult networks for a pediatric health system? What are the financial implications for all of the mergers that are happening throughout the nation? So you need to be able to develop some of that expertise internally. And then the last one is the understatement of the year. Financial sustainability is complex. We know fee-for-service will maintain, and we know that we need to evolve to some of our value-based models, and we know that that transition is going to be difficult. We have the benefit of being able to leverage a health plan. Not every system can do that. And even in leveraging that health plan, we will feel significant financial pressure during this transition. And so we have to be planful about how we approach this in a way that allows us to be the independently governed freestanding children's hospital that we are right now, which is our goal. So that is my contact information. I will stop here, and I think we have about 10, 12 minutes for questions.
Fabulous presentation. We have some time for questions. Let her know who you are, because that may put your questions faster.
Good morning. I'm Mary Damont, Vice President of Revenue Cycle and Care Management, so you really speak to my heart. I also have a 10-year background in public health, so I love the community outreach centers that were set up. I think it's just marvelous. But what is the financial sustainability plan for that work?
Yeah, that's a very fair question. And as I had shared, the community clinics were not something we ever sought to embark upon, ever. They are serving kids who by and large are insured. So the children are insured by Medicaid in those clinics. The adults by and large are not. They are uninsured, which is why we're very careful about advertising the clinic is for children and their caregivers, because frankly we could not afford to do an adult clinic for uninsured individuals. We could not sustain that. Our current sustainability model is this is a very intense collaboration. Children's Hospital of Wisconsin employs the nurses, the care managers, the front office staff. Marquette University School of Nursing is our clinical provider in this, and we use a family practice nurse practitioner model so that their faculty that provide the care, they document in our instance of electronic health record. And the clinics are located in community centers. The community centers have invested in doing the build-out, and this is a rent-free arrangement. So everybody has skin in the game, if you will. And still, these clinics lose a fair amount of money, at least we experience a fair amount of loss every year for those clinics, which we attribute, frankly, to this is part of our investment in the community.
Other questions?
Thank you for an excellent presentation. I am Desiree Delator, the Director of Community Affairs and Population Health Improvement. So your presentation spoke very highly to me as well. My question is regarding the payment and the payer mix that you were describing. I totally get the population health management because many of the Medicaid patients belong to Children's Hospital of Wisconsin. Could you describe the payer population and that mix, please?
Yeah, and let me also make sure, Desiree, I got your all aspects of your question correctly, that we are we're the only freestanding children's hospital in the state. There is American Family Children's Hospital, which is incorporated with the University of Wisconsin system, and they're about 90 miles west of us. However, when you look at pediatric hospital admissions, we only have about 67% of those admissions, which is interesting because the adult systems, I said they're picking off some of the more commodity services, number of straightforward, simple pneumonia, some orthopedics, the TNAs are being admitted at adult hospitals. Our payer mix is over 52% Medicaid. Now, of our health plan ensures adults and kids, but by and large, of the 143,000, about 93,000 are kids. Those kids are across 13 counties in southeastern Wisconsin. So only about a third or just under a third of those CCHP members actually get care within our system. So those are the two nuances that you were getting at. So when we utilize that health plan for testing, it is very helpful to do that because of the size of the plan. We have enough kids to be able to test some of these and not have quite a significant impact financially on hospital revenues. There's a question from the WebEx, I think. Question from the WebEx. Go ahead.
Could you please expand on how school nurses collaborate with your primary care team to improve asthma care, and were efforts primarily centered on controlled medications, or were you able to address indoor air quality issues in the schools or in home?
Great question. So, in full spirit of transparency, our school nurses are employed by Children's Hospital, trained and placed full-time in 9 public schools in our partner communities. They document in EPIC, so they have to double document because school nurses also have to document in the school system, and one day we will get FERPA and HIPAA to collaborate, but not yet. So they work with primary care practices in this way. So for example, when I see a patient who attends one of the schools where we have a school nurse, and the child has any condition, but we'll use asthma, I will put in my asthma action plan and we'll send a message basket to that school nurse saying, Veronica's having a hard time making sure she gets her controller med. Would you administer the med in school so we can be sure that she gets it? That's how we utilize that. It works bi-directionally too. School nurses can let the primary care practitioner or the asthma specialist or the pulmonologist know that a child is struggling in the school setting. That's how they work as part of the care delivery team. It is not nearly as smooth or as pervasive as we would like for it to be. It is clearly well used by the early adopters, the early adopter primary care providers. In terms of addressing indoor air quality, the model that the school nurses employ is one called Coordinated School Health. It is a CDC-based model, which is 10 components that address the whole health, the whole environment of a school, not just healthcare delivery in a school. However, those school nurses do that work in partnership with the school administration. So I don't think any of our school administrators have identified indoor air quality as a priority for that school. As regarding asthma management for air quality in schools, that has not been a focus.
Okay, we have time for about 2 more questions. I'm going to have Mark and then, 3 more questions.
Okay. Hi, I'm Francisco Alvarez, one of the pediatric hospitalists. I'm kind of piggyback on the previous questions about all the adult institutions and healthcare networks in the sense of the large amount of volume or patients that are actually seen in adult areas, especially when you look at EDs, see a lot of pediatric patients. How are you approaching these adult institutions and healthcare networks in the sense of aligning that population health component when they're doing a large majority of the care?
It's a fair question, and I'm trying to figure out how to respond to it delicately. With caution. And so let me tell you what I mean by that is our greatest competitor is not our colleague 90 miles west. Our greatest competitor are the adult systems that are trying to get healthy kids as part of healthy commercially insured kids as part of their population to balance some of the risk exposure that they currently have. So some adult systems are less interested in a message about our skills in pediatric population management and how we can work effectively. That said, part of our work and part of our mission historically has been serve everyone, work with everyone, and because of that history, it's hard for even those competitive adult systems to completely walk away from working with us. So, for example, in the provision of care in our community, one of the adult systems is one of our partners in supporting child health in those communities. It continues to be a bit of a challenge, but we also have to be committed to this. So we can't do this alone, and we know that the adult systems are heavily invested and aren't going to give up kids. We have to figure out how to do this in partnership, which is our approach with them. We have to work collaboratively.
I'm going to have one more question. I'm going to have you join her later, and then Dr. Newman is going to conclude. So go ahead, Mark.
Hi, I'm Mark Weissman. I'm in primary care and community health, and you have a really great story. Realize that it's still a work in progress. As you have shifted kids into value-based contracts, how has your health system worked with the hospital and specialty providers who historically have been compensated based on value and RVUs and productivity? And have you changed those models to address population health outcomes or reducing expense that previously used to be revenue?
Yeah, $64 million question, right? A couple of answers to your handful of questions. One is that we have shifted, mostly the contracts that we've shifted to value are Medicaid-based. So commercially, we have one commercial contract that has some DRGs, some form of stayed payment, and certainly P for P, so early value-based arrangements. Providers from across the system, primary care, specialty care, hospital-based providers, were integral in identifying what were the measures for success, for performance, for those value-based contracts. We had to engage providers in that work because they're the ones that are going to be held accountable to that performance, right? And so they were integrally involved in the development of those contract measures. In terms of incentives, from our primary care practice, these are our employed physicians, we have just this year changed compensation models to account for contribution to value. And that, you can imagine, is a substantial change for practitioners. For our specialty practice, which is the joint venture, we've not yet gotten there. And it, again, like your experience, part of the challenge is they are employees of the Medical College of Wisconsin. And while we are philosophically aligned, the challenges as to how one is paid in an academic setting and incentivized in a clinical setting are a bit challenging. We fortunately have great partnership with the Medical College and its leadership and with the provider practice to figure out how to do this. And you have one more component to your question, though, as well, didn't you? Okay.
Dr. Weissman could go on all morning. Thank you, Veronica, and I just want to thank all of you for attending and your engagement here. I'd like to invite you to the South Conference Room at 9 o'clock if you have want to discuss things further with Veronica. We're hosting a discussion up there, but I want to thank you for really sharing sort of the frontier of what is a brave new world, and you're hearing from one of the real champions and one of the organizations that is on the front line of this change for all the right reasons. And I think Veronica has shared a lot of the lessons learned, things they might think about doing again, and some of the issues that they're currently facing. And if you look at, as she pointed out, our health systems, they're very similar in organization. When I think about our school nurse program in the District of Columbia, now in also in Montgomery County, and now I think we just signed a contract in Prince George's County. Our mobile health, the clinics, the two emergency departments, the mobile health, mental health, dental health, and then the hospital, 600 specialists, 1,400 pediatricians in the Children's National Health Network. As we weave that together, we have to be cognizant of the changes around us. Now, fortunately for us, we don't have any of these big competitive adult health systems around us. You know, I'm just joking, you know. You know, and so the challenges are very similar. So I think it's wonderful in the children's hospital world, independent, locally governed, focused with a very similar mission to be able to share these things. We're behind. We're not there, but we need to get there fast because we already feel the market changes, and when it shifts, I don't know that it'll be that you have the luxury of that nice long trajectory that Veronica showed in Milwaukee and in Wisconsin. It's going to probably here it'll be more like a cliff, and if we're not, you know, moving along that way, and we're already starting to do the work to be prepared, then we are, you know, we're too small to contend with that on our own. So that's why these types of rounds and sharing are so important. Denise, Elizabeth, thank you for making it possible to have Veronica here today. I'd like to see as many of you as you can come up to the South Conference Room at 9 and for a little bit and share some more conversation. So thank you all very, very much.